Welcome to MedEd's third edition of the Cardiac Medical and Cardiac Surgical Examination Certification Review. My name is Cammy Fancher, and I'm the presenter for the modules for this review course. We've already done Module 1 and 2. This is Module 3, which is a pretty good review of cardiac assessment. On both examinations, there are questions about heart sounds, physical assessment keys. So this is actually a very important module, and it goes over everything. All right, let's get started. Now, where do you think you do your best assessments? I do my best assessments standing in line at the grocery store, and I look at people, look at these people. Like one guy looks a little jaundiced. You look at somebody's legs, and you say, oh my gosh, they have heart failure. Look at those legs. This guy has COPD. He's tripoding. You look at somebody and go, oh, I could get an IV in that without a tourniquet. We are nurses. We always do assessments, and we do them very well. Maybe not so much on our family members, but we do them really good in public. I have children, and when they were a little bit younger, not so much now, they're adults, but I would say, oh, go around the other way and take that person's picture. And they would say, no, Mom, I can't do that. I go, yeah, it's a perfect specimen. Look at there, they're diabetic, they have COPD. We do assessments all the time. Your eyes are trained to see a lot of things in a very short time. When I walk into a patient's room, I look at the monitor, I look at the suction cannular, I look at what position they're in, I look, are they engaged with me, what color are they, what temperature are they, I look at all the equipment in the room, and that's probably in the first second that you walk in. So general assessment occurs very quickly. Essentials of the assessment are vital signs, and remember those vital signs. In one of the first chapters or modules, we went over vital signs: blood pressure, heart rate, respiratory rate, and temperature. Don't forget the pulse pressure. But really, in the cardiac assessment, it is really, is there perfusion? Is the heart perfusing the heart well enough? Such as, when I do a cardiac assessment, I say, is the patient warm and dry? The skin is not a very high oxygen demander. So the first place that your blood flow is deviated away from when things are going wrong is the skin. So if you're warm and dry, your perfusion must be okay because your skin is being perfused. If you're awake and alert and you're mentating all right, your brain is getting enough oxygen, glucose, and if you're making urine. So the things that I kind of look at is the patient awake and alert, warm and dry, making urine. If all those things are real, their perfusion is okay. If something begins to alter, we look at those three things. Now, don't write this on your evaluation, but I happen to love Foley's because I always want to know how much urine output the patient's making because that is a sign of general cardiac function. Now, remember what we do for a living. We always want to enhance oxygen delivery and decrease demand, so we use our assessment tools to figure that out. So a critical assessment is really observation, and it also includes palpation, percussion, and auscultation, a real physical exam. Now, in my early years, we did percuss the heart to see the borders of the heart. We don't do that anymore. We have x-rays, we have echoes, we have much more advanced equipment. We don't do that. But you do look at the patient, you can palpate, and you listen. So you need good ears and a good stethoscope to do this. And you do it in a systematic order every time. So when you develop your physical assessment skills, you're going to do your physical assessment the same way each and every time so you don't forget a part or get out of sequence. Cardiac function, cardiac, is it meeting the demands of the patient? Righty, how to maximize their cardiac function and to protect the other organs, the liver, the lungs. Okay, so inspection, look, feel, what does the patient smell like? Inspection, overall appearance, what's their mentation? Are they awake and alert? That's a good one. Their color, their breathing pattern, and their temperature. The heart and lungs cannot be separated. We always talk about cardiopulmonary function. So we're not just assessing cardiac function. When you listen to the heart, you're going to hear the lungs. If somebody's breathing 30 times a minute, that's not right. You have to figure out what's going on with the patient. Chest wall, palpations, and the patient really should be naked. Now, if you want to be very specific and very exact, When you're doing a patient's cardiac exam, you should be on the right-hand side of the patient. If the patient's either on an exam table or in the bed, you should be on the right side. And the reason is you then have a tangential view. You're not looking straight down at the chest, but a tangential view of the left chest where the heart is. You can look for pulsations. In a thin person, you might see pulsations, and then you would feel them, and then you would listen to them. So chest wall movement, abnormalities, what's your chest look like? Are they barrel-chested? If somebody's barrel-chested, you know you're not going to hear the heart way over here. You're going to hear the heart in the epigastric area. If they're concave, if they have pigeon chest, you know, you're going to be able to look and then feel and then hear. So the first thing you're going to do is have the patient lay down and be comfortable and feel with the flat part of your hand. And you're going to feel for any type of pulsation or rocking movement. If somebody has biventricular failure and they have an enlarged heart, a big, baggy, you know, right and left ventricle, when you put your hand on their apex, or where you think the apex is, you might even see this. We call that the rocking horse chest wall, and that's indicative of right and left ventricular failure. And you may see that. You may see it and then feel it. In a normal person, the PMI, point of maximal impulse, is very discrete. You feel the heartbeat, and it's just pinpoint. So after you kind of feel with your hand, you're going to decide with the top parts of your fingers. When you use your hands for physical assessment, and your fingertips are very good at feeling the size and exact location of something. Palm of your hand is not too sensitive. If you're feeling temperature, you should use the dorsal part of your hand because this is much more sensitive than this to temperature. So I feel the point of maximal impulse, and then I'm going to listen, right? If I feel a thrill, I know I'm going to hear a bruit, which means a murmur. You feel thrills, it's easy to remember, and you hear bruits. So if I put my hand on someone's chest and I feel a vibration, I know I'm going to hear a murmur. And I want to listen to where I felt that vibration the strongest. So you feel a thrill and you hear a bruit. But I want to look at specific parts of the heart. Specific parts of the heart. So I look at these areas. I'm going to look at the aortic area, pulmonic, aortic and pulmonic, apical and epigastric, and I'm going to listen with the diaphragm. So here's the areas. To the right of the sternum is the aortic. To the left of the sternum is the pulmonic. And then I don't usually look at that third space in the third intercostal space. I go right to the right ventricle, the apical, and then the epigastric. So I'm going to feel in all these areas, and that's also where I'm going to listen. And I'm going to listen with the bell of my stethoscope and the and the diaphragm of my stethoscope. Mighty auscultation. It's something people always ask me, Cammy, teach me heart sounds. You know what? It's very difficult to teach heart sounds. The best way for you to learn heart sounds is to get a good stethoscope and listen to all your patients. And go look at the progress notes and see what kind of murmurs they have. Sometimes you don't hear it, sometimes you do. Murmurs do change with the hemodynamics of the patients, the way they're sitting, the way they're standing, or their volume status, right? So when you use your stethoscope in those 5 areas, you're going to listen to rate, rhythm, you're going to listen to S1 and S2, and see if you hear any other heart sounds. If you work in the ICU or in the step-down unit where you have a monitor right there, it's easier to discern S1. That's the aortic valve opening because the heart is squeezing. That's the beginning of systole. You see a QRS, and then you see diastole. So you can hear, you can kind of pinpoint S1 and S2 and listen for extra sounds. So listen in order. First and second heart sounds. This patient's laying down comfortable. This is my friend TJ. She's a nurse practitioner, a cardiac nurse practitioner. And she's listened to the aortic, the pulmonic, and right ventricle. And now she's looking right at the apical impulse. And she's listening, S1, S2, and looking at the timing. You can even feel the carotid if you don't have a monitor to feel for the timing. Now, if you think you hear a murmur or you think you hear something, an extra heart sound, you can change the position of your patient. If you sit up and lean forward, in some patients, that's going to bring the heart closer to the chest wall. Righty? So this is a technique for listening. And so I'm going to move the patient over, lean them over, exhale completely, and hold their breath, if they can. It accentuates aortic murmurs, so aortic stenosis you'll hear very well in this position. The other position, and I want everybody to do this, this is your homework for tonight. When you go to bed tonight, I want you to lay on your back and put your hand over where you think the apex of your heart is. You probably aren't going to feel anything, maybe a little tiny tapping. But then I want you to roll over on your left side, put your left arm under your head, put your right arm down by your side, and lean over just a little bit. Lean forward and put your hand under there, and you will feel your left ventricle beating up against your rib cage. And you'll be able to discern it very discreetly. So roll the patient over. This also accentuates S3s and S4s, mitral murmurs, especially mitral stenosis. You'll hear very, very well in this position. So it's always about location, location, location. Now this is a very important slide. Ready? There are several, especially on the cardiac medical, there are questions about heart sounds. Cardiac surgical has one or two, cardiac medical has a few more. So let's look at this slide together. As you're looking at the slide right in front of you, the first big line is S1. Right? S1 is the aortic valve opening, mitral valve closing. This is very easy to remember. The left ventricle is filled, and now it's going to contract. We're starting systole, so it's going to contract. If your ventricle contracts, the door has to open, the aortic valve has to open and get blood out the aorta. Then you have ejection. Then you have S2, the aortic valve closes, the mitral valve opens, and now you begin diastole. Diastole is always longer than systole. If we have perfect sinus rhythm in the 70s, you have 1/3 systole, 2/3 diastole. And that's why when you're looking at mean arterial pressures, it's not systole plus diastole divided by 2. That would be an average. It's a mean. It's systole plus 2 times diastole divided by 3. That's how you get a mean arterial pressure. So diastole is longer. Why? The ventricle is filling and the coronary arteries are filling. So let's look at this a little bit more carefully. If you look at the S1, you see that little line above it. That's the end of diastole. S1 is the beginning of systole. So as the heart, all the valves are closed and the heart is resting at the very end of diastole, the pressure in the left atrium is about 10. The left ventricle about 10 at the end of diastole, and the pressure in the aorta is 80. So I can't get blood from a pressure of 10 into a pressure of 80. I can't do that. I'm going against a gradient. So the first thing that happens in systole, with all the valves closed, the aortic valve and the mitral valve are closed, is the ventricle begins to contract. That's isovolumetric contraction. That is when the heart is using the most oxygen and the most work. Because what it has to do is generate a pressure greater than 80 so you can pop open that aortic valve and slam blood out and get ejection. So first you have isovolumetric contraction and then you have ejection. That's when your heart is really working. Open up that aortic valve. Now the aortic valve closes, the mitral valve opens, and now the ventricle is filling. During systole, remember that your heart does not eject every cc of blood, only about 60%. So if there was 100 cc's in your ventricle, 60 cc's went out, and over in that diastolic period, there's a little bit of blood left in your ventricle. Your ventricle never wants to be empty. If it empties, the patient fibrillates. You know, when people die of exsanguination, they bleed out and their heart fibrillates, and then they die. They have no perfusion. So 60% ejection fraction, so you have a little bit of blood left in that left ventricle. So now let's talk about diastole. In early diastole, the mitral valve opens, and the blood that was in the atrium just falls into the ventricle. We call that passive fill, and you don't hear that sound. You don't hear that noise at all, at all. At the end of diastole, in normal sinus rhythm, the atria contracts and pushes more blood into the ventricle. That's end diastolic filling. Righty? That's when you have the ventricle at end diastole after the atria has contracted, and so we used to call that atrial kick. Remember atrial kick? And now we just call it fulfilling. That is how your ventricle gets filled. Alrighty? So that's how it works. Now how we look at heart sounds, we'll talk about S3s and S4s and where they occur. Well, let me go back for a second. Let's talk about S3 and S4. An S3s and S4s are always pathological in the adult. Remember, we're only talking about adults. So in S3, you have S1, systole, S2, diastole. Occurs very early, right after the S2. And what happens in a patient who is in heart failure, you know, they have a 10% ejection fraction, their ventricle is full, 100 cc's, it squeezes, only 10 cc's goes out, so in early diastole, that ventricle is still full. When the mitral valve opens and blood falls in, early, very early in diastole, now it's going to cause turbulent blood flow, and you're going to hear it. You're going to hear an S3. It always tells you that the patient is volume overloaded. Righty? S3, always volume overloaded. Now let's talk about that S4. Again, it's always pathological, and it happens at the very end of diastole, and it happens right before S1. Now what happens here is, remember that in early diastole, blood just falls from the atrium to the ventricle, and we shouldn't hear that unless the patient's volume overloaded. And at the end of diastole, when that atrial contraction occurs and pushes more blood into the ventricle, we used to call that atrial kick. Now we just call it preload, the amount of volume in that ventricle at the end of diastole. If the ventricle is very stiff, patients had long-term hypertension, they have aortic stenosis for a long time, and that ventricle is thick and stiff, now when that atria contracts, it has to pump really hard to push that blood into that stiff ventricle, non-compliant ventricle. You make turbulent blood flow, and you hear an S4. So you will hear a chronic S4 in anybody who has aortic stenosis or long-term hypertension. Acutely, what can happen and make you hear an S4 is an acute STEMI. Once that area of the myocardium has infarcted, that part of the heart becomes stiff. So you may hear acutely an S4 with a STEMI. Right? You have chronic and acute. Okay? So S3s and S4s are always pathological. S3, volume overload. S4, non-compliant left ventricle. All right, good. Now, murmurs, we talk about murmurs in timing, diastole or systole, systolic murmurs, diastolic murmurs, location of where you hear it the best, and does it transmit? Does it transmit up to the carotids? Does it go to the axilla? Where does it go? So systolic murmurs are aortic stenosis, a very big one, you'll hear that a lot, mitral regurgitation, you can hear that a lot, or a VSD, or ruptured papillary muscle. And here's where they like to ask you a question. They'll say, you have admitted a patient with an anterior septal wall infarction. They're doing well, but all of a sudden the patient's heart rate goes up, they complain of shortness of breath, they look like they're going into acute pulmonary edema, and you hear a loud systolic murmur. That's a ruptured papillary muscle. And the keys are septal wall infarction, which means the papillary muscle 2 to 3 days later ruptures, and you have acute mitral regurgitation, and you hear this loud murmur. Okay, that's a classic thing on the exam. And that's a classic thing because now we have to pick it up, call the doctor, because that patient needs to go to the OR. We can put a balloon pump in. We can do a lot of different things to have a time delay, but the real key of that is the mitral valve repair. Okay. Diastolic murmurs are mitral stenosis and aortic regurgitation. And a lot of people have mixed, but this is where you hear the mitral stenosis, which is a big one, and aortic regurgitation. All right, so here's what you see. Now this is just a phonogram of where you see the murmurs. So normal S1, S2, right? Aortic stenosis, that's a systolic murmur. Mitral regurg, little murmur. Now that aortic stenosis is a crescendo, decrescendo. It looks like a bell, so you hear it, then it tapers off. Now it's only during systole, which is a very short time. So it would be nice if the patient had a heart rate of 60 so you could hear it. Sometimes if their heart rate's 120, it's very hard to hear. Aortic regurg, long diastolic murmur. PDA, a patent ductus arteriosus, as you hear it all through systole and diastole. A holosystolic murmur, aortic stenosis. You hear it all the way through. Righty? So those are the ones. You really need to know aortic stenosis and mitral stenosis and mitral regurg. But if you know that one slide where S1 and S2 is, you know where systole is, you know where diastole is, you can tell where the murmurs occur and where you will hear them. This is how we grade murmurs, and this happened a long time ago. And I used to say a grade 1 murmur is 1 cardiologist out of 6 hears it. It's very faint. You have to have really good ears. A 6/6 is you're standing at the foot of the bed and you hear the murmur. In the old days, when we used to get people with really bad rheumatic heart disease, and they would have all of their valves would be insufficient, and you would stand at the foot of the bed and it sounded like a washing machine. They're all systole and all diastole, and you could stand at the foot of the bed. You do still see that in developing countries where people don't get strep throat, identification and treatment. But here we don't usually see that as much as we did 4 years ago. So what sound do you hear? Is it new? So this can confuse you sometimes, because say you have a medical patient being admitted, there's no beds in MICU, and you're admitting a patient from the ED with pneumonia, and he has COPD. So he has high pulmonary pressures, righty, and now he has pneumonia, which makes the pulmonary pressures go higher, so that puts a big afterload on the right heart. The right heart dilates, and now you hear a tricuspid regurg murmur. When the pneumonia goes away, a systolic murmur. When the pneumonia goes away and the PA pressures come down, that murmur goes away. So sometimes disease states can accentuate murmurs because we're changing the hemodynamics of the lung and the heart. So sometimes you see that. On the test, what you really need to know is that acute mitral regurgitation. That's a big one. And are there any other changes in the patient's physical examination? Okay. The arterial system, we're always feeling for pulses, and we all know that if you have a radial pulse, you should have a brachial and an axilla. So I would just go for the brachial. You also know that for a good peripheral arterial exam, you have to do both extremities, and you compare one extremity to the other. Not your extremities, the patient's extremities. So if I have a 2+ radial pulse here, I should have a 2+ radial pulse here. Righty? If this hand is warm, this hand should be warm, and I use them as the constant. So the arterial system, inspection, palpation, rate and rhythm, amplitude and contour, and blood pressure, using the correct blood pressure cuff. Right? That's the hardest thing for me. Sometimes we do have some obese patients, and I can never find those great big cuffs for those patients. Looking at arterial waveforms, there are no waveforms for you to analyze on the exam. But number 1 is normal, weak pulse, bounding pulse, bifurens pulse, which means you have like 2 dicrotic notches. Pulses alternons. So this is the one I want you to pay attention to. This is not a patient that's having PACs or dysrhythmias. They are in sinus rhythm, completely normal rate and rhythm. But you have a bounding pulse. This is arterial pulse. A bounding pulse and then a weak. Bounding weak, bounding weak. That is a very early sign of heart failure or left ventricular dysfunction. And you may see that in your heart failure patients if you're lucky enough to have an arterial line. So very early sign of heart failure. Bigeminal pulse, that's because of PACs. But look at the bottom one. That's another one that's very important. Paroxysmal pulse, which swings with inhalation and exhalation. When you and I breathe, our blood pressure changes a little bit. But if I take a really big, deep breath in, and I increase my pulmonary pressures, I actually decrease venous return, and my systolic blood pressure should drop a little bit, but not much, maybe by 5 millimeters of mercury, maybe 6. But if I have swings of more than 10 millimeters of mercury between inhalation and exhalation, it means I'm paradoxical. It usually means, it can mean that I'm intravascularly dry or that I have very high pulmonary pressures. Very high pulmonary pressure. A patient with a pulmonary embolus might have that. A patient with bad pneumonia and high PA pressures, you may see that. A patient is hemodynamically unstable because they're volume deficient, you may see a paradoxical pulse. Now remember, this is not the EKG, this is arterial line pulse. This is arterial flow. Good. Right. You have a radial and a brachial artery, and because your palmar arch has two distinct arterial blood flows, the ulnar and the radial. So before you put an arterial line in anyone, you're supposed to do an Allen's test to make sure that the ulnar can still feed the hand. And the old way of doing that is to have to compress both arteries, let go of the ulnar, and look at the color change in the hand. But that is very subjective. Are they pink? Are they white? How many seconds does it take? It's very subjective. So a modified Allen's test is to put a pulse ox on the thumb. The thumb has bilateral, both arterial blood supplies. Put a pulse ox. You have a pulse of 70 and 100% saturated. You compress the ulnar and the radial. Compress it till you get 0. Let go of the ulnar. Keep the radial. And what should happen? Within a second, you should get rate and 100% pulse ox. So now you can say return to flow in 1 second, 100%, 100%. That's pretty scientific, pretty good. So I feel comfortable putting a radial artery line in the patient. So arterial perfusion. Now, I know nobody does this anymore for looking at JVD and measuring jugular venous distension. We just don't do it anymore. We do echoes. If we have any question about the heart, we do an echo, which gives us really good information about structure and function of the heart and great vessels. But if you're going to look at jugular venous distension, you measure it from this angle, and you look at it. It's hard to see here, but this gentleman does not have any JVD. He's at 45 degrees. You and I would not have any jugular vein distension. We wouldn't even see the jugular vein. So if you're going to look at the jugular vein, it's rarely palpable. You can't feel it. It's not an artery. It undulates. It has an AC and V wave just like your CVP. It is a measurement of the CVP, right? It eliminated by pressure. So if I put my finger lower, I could obliterate the whole thing. And the level of the pulse, inspiration, it may change. It may go up and down. It varies with position if you stand straight up. So your carotid, however, should be palpable. It's one component. You can't eliminate it, and it's unchanged. Hopefully you feel the carotid when the patient is sitting up and laying down. So those are the differences between the two. And we sometimes look to see if the JV is distended or not. Our heart failure specialist still use this as a very good sign to see about volume. But I'm going to give you a question mark here. If somebody has high pulmonary pressures, or they have right ventricular failure, but their left ventricle is normal, what will the CVP be? Normal left heart, an acute right ventricular failure. The CVP will be very high, because as the right ventricle fails, that pressure in that right ventricle goes up, and the pressure's got to go up during diastole. The pressure is going to go up in the right atrium and in the jugular vein. So your CVP is going to be elevated. It does not always tell you what's happening on the left side. If they have just right ventricular failure, you have no idea what the volume status is on the left. If you have biventricular failure, the CVP says, it's 15, you're volume overloaded. All right? Be very careful about that CVP. Now, if the patient's at 45 degrees and you're looking at the jugular vein and it appears to be distended, and you have a heart failure patient and you push up on the liver, if that patient has liver congestion, the jugular vein will get worse. The JVD will get worse. That's hepatojugular reflux. And we see that often in right ventricular failure patients. Right, and there you go, pressing up on the liver, looking at the JV. Now, what you see in this gentleman laying down is not his jugular vein. That's his internal jugular. This is his external jugular vein. All right. Peripheral evaluations, you're going to look at venous and arterial perfusion. You look at the legs, so they have a sock sign. Now, be very careful, because a lot of athletes that wear really tight athletic socks may shave their legs or may have very poor hair distribution where their socks are. It's not an example of arterial insufficiency. Right? Look for varicose veins, venous stasis. The patient sitting down, their legs are purple. You put them up and they turn pink. Venous stasis. Older age female, overweight, inactivity. Smoking has a big deal with veins as well as arteries, and family history. Swelling, well, a lot of different things can cause leg swelling. It's not always heart failure. It can be salt abnormalities, thyroid abnormalities. My legs are swollen at the end of the day after working 15, 16 hours because I'm old. I have great arterial perfusion, and I don't even have varicosities, but when you're standing up for 8 hours and drink a Diet Coke all day long, your legs swell a little bit. So look at the peripheral evaluation. This is looking at varicose veins. You see a normal vein with valves, right? So it keeps blood going in this good direction. And here you have incompetent valves and a distended, almost aneurysmal-like vein, which can cause a lot of pressure, discomfort for the patient, more index of suspicion of having blood clots in your legs. Right? There's a great example. On the right there, you see a normal leg, and on the left, horrible varicosities. Now, sometimes today you don't see that because we don't do vein stripping anymore, but they can inject or do laser and get rid of those. But you know, one day you might need your saphenous vein, so be careful, be very careful with that. Now here's an example, 2 different patients with horrible heart failure, and the one on the right, because it's so red, looks like cellulitis, but what it is the one on the left is brawny, is brown from having continuous venous stasis and swelling in their legs, and actually changes the color of the skin. The one on the right is, again, this is more acute venous stasis with no cellulitis whatsoever. And it's red on both sides with the brown spots, but both are swollen for a while. So cardiovascular exam, what did you find? Did you see inspection, palpation, auscultation? What did you find and put it all together? Does the patient look like they have heart failure? Do they look like they have arterial or venous insufficiency? And remember, are they awake and alert? Is their skin warm and dry? And are they making urine? Those are really the essentials of a cardiac examination. And you put it together. For the exams, they're going to go more into the hemodynamics and the heart sounds. Heart sounds will be very important for the examination. Now let's talk about hemodynamics. Many of you may never have seen a PA catheter even used if you work in, in the cath lab, if you know hemodynamics, of course. But when you get to the ICU or the step down, you don't have a PA catheter. Both exams have questions about PA catheters and the movement of blood through the great chambers. Hemodynamics, that word means the movement of blood through the heart, the chambers of the heart, and the great vessels. And why would we use this? Well, a lot of people don't use a PA catheter anymore because you have to do a central line stick, and you have to understand the waveforms, and you have to understand the meaning of the waveforms. But why we use it is not just for the pressures within the heart. You can get samples, but for cardiac pacing, but for the use of the delivery of oxygen and the use. With a PA catheter, it was the first time in the 70s that we could measure how much oxygen we deliver and how much is being demanded by the heart and the great vessels. So there are a lot of pros and cons to using it. We're just going to go over it because it's going to be on your examination. Many hospitals don't use them at all. Many MICUs don't use them at all. The patients that may have PA catheters are your very sick, high acuity cardiac surgery patients. A simple bypass surgery, that patient may come out and only have a triple lumen, no PA catheter. Right? But if they have a very poor ventricle, if we're doing ventricular protection or heart protection, cardiopulmonary bypass protection of this patient, they are at great risk for induction for surgery, for having a STEMI or a non-STEMI, that will put PA catheters in and monitor more carefully. So there's your numbers, the numbers that you need to know. And so let's put in a PA catheter. We're going to go in through the right IJ and put this PA catheter into the right atrium. And a couple of things in the next couple of slides, I'm going to talk a lot about heart failure because that's on the exam. The key to remember is that in embryology, when you were developing, your heart was a muscular tube. It was just a tube. And then through your development as an embryo into a fetus, that muscle turned and twisted into 4 chambers and your great vessels. But blood enters one and comes out the other. Blood all goes in one direction. There is really no such thing as backward flow. If the right ventricle fails, the pressure gets high, Blood doesn't flow backward, but it's very difficult for the atrium to pump blood that way, so that pressure has to get higher, and this pressure gets higher, and that pressure gets higher. If you have backward blood flow, if blood is going from your left ventricle to your left atrium, you're dead. You've got to have blood going in a forward manner, or you don't have anything coming out to the aorta, and the patient would die. So it's not a matter of backward flow, it's a matter of the pressures changing and difficulty of forward flow, or poor forward flow. So let's go into the right atrium, go to the right atrium, like your CVP, and normal right atrial pressure is about 5 millimeters of mercury. It's very low. When you're at work, maybe it's 1. You don't drink. You don't drink enough water to get dehydrated. But it's 5 millimeters of mercury. Who's ever putting it in is going to ask you to blow up the balloon, and from the right atrium, it floats into the RV. But I want you to look at that picture. The pulmonic valve is closed, and the tricuspid valve is open. Look at the right side. It's white. Right atrium, right ventricle. The tricuspid valve is open. The heart is in diastole. Pulmonic valve closed. So the right atrium and the right ventricle are communicating. Blood flow is communicating, so it is in diastole the same pressure. So I have 5 millimeters of mercury in the right atrium. In the right ventricle, the diastolic pressure is 5. But then the tricuspid valve closes and the right ventricle contracts, and now you have a bigger systolic pressure. So the pressure in the right ventricle is about 25/5. That's very important. Okay, 25/5. If I have acute right ventricular failure and it goes to 35/15, what's my right atrial pressure going to be? What's my CVP going to be? It's going to be 15. Whatever the diastolic is in the ventricle is going to be the pressure in the atrium. So if it's 30/10, my CVP will be 10. If it's 45/20, my CVP is going to be 20. It has to, because that atrium has got to pump blood to the ventricle, to the pulmonary arteries, to the left side of the heart. It has to go that way. So 5, 25/5, and now that right ventricle is pumping blood through the pulmonic valve into the pulmonary artery, and the normal pulmonary artery pressure is 25/10. A little higher diastolic pressure, but it's not communicating. That mitral valve, that pulmonic valve is closed. So 25/10 is the most normal pulmonary artery pressure. That's important. What does that number tell me? It tells me the pressure inside the lung parenchyma, where the alveolus is in the capillary bed. The pressure in the lung, normal. You've never smoked before, you don't have asthma, you don't have pneumonia, you're not hypoxic, you don't have anything wrong with you. The pressure inside your lung is 25/10. Now what makes the pressure go up? Well, if you have COPD, asthma, chronic emphysema, chronic bronchitis, because there's destruction of tissue in your lung and it makes your lungs stiff. Anything that makes anything in your body stiff, the pressure has to go up. So the pressures go up. So COPD, asthma, you may have never smoked, but you have asthma, you might have pulmonary hypertension. Heart failure, right, would cause pulmonary hypertension because you have fluid in your lung. Pneumonia causes pulmonary hypertension. Hypoxemia. So when your patient becomes hypoxic, or if I take you to the Plano Alto, which is 20,000 feet, and there's no oxygen there, your pulmonary arteries and pulmonary veins are going to vasoconstrict, and your pulmonary pressures are going to go way high. That's how you get flash pulmonary edema from altitude, right? So those are all things that make it go up. And a pulmonary embolus, big one, pulmonary embolus, right? So you've never smoked, your pulmonary pressures, your right-sided pressures are all normal. You have you get off an airplane, you have a large pulmonary embolus, your PA pressures go up really fast, the right heart dilates and fails, and you look very sick when you're very hypoxemic, you can't breathe, you're starting to turn funny colors, you might have dysrhythmias, right, from pulmonary embolus. What makes the pressures go down in the pulmonary artery are things like you're bleeding, you're exsanguinating, or the right heart is failing. If the right heart can't pump blood into the pulmonary artery, you're not going to have pressure. Right? So now let's wedge the catheter. So at the tip of that catheter is a balloon. The tip of the catheter is a balloon, and so what it will do is, you're in the main pulmonary artery, it'll wedge in one of those little smaller pulmonary arteries. which means that the balloon is inflated and the tip of the catheter, which senses the pressure, is looking that way, and everything this way is occluded from the catheter. So in essence, the wedge pressure, which is going to be always lower than the PAD, pulmonary artery diastolic, it has to be less than 10, 8, 9, it could be 10, but it should be 8 or 9 or even 6, all right, your wedge pressure, tells you the filling pressure of the left side, because from that pulmonic valve, and trace it all the way down the pulmonary artery, all the way pulmonary capillary, all the way pulmonary vein, all the way back to the left atrium, there are no valves. It's a contiguous circuit. So when I'm looking down there, I'm seeing the pressure, the pulmonary artery, pulmonary capillary, pulmonary vein, left atrium. So the wedge pressure gives me an indirect reflection of left atrial pressure. So let's have a very special catheter. It's called a Cammy catheter, and we're going to snake it all the way through the lung into the left atrium. What's the pressure in the left atrium? 4 to 10. Left atrial pressure is very low. It's very much like the right atrium, a little bit lower, 4 maybe to 10. And now put that catheter in the left ventricle, because isn't that what we want to know? We want to know left ventricular function, left ventricular filling. How's that left ventricle working? What's the volume status of the left ventricle? Left ventricular pressure is, now you have to be careful. Remember that mitral valve. Look at that. Look at the slide. Look at the slide in front of you at the shaded in area, left atrium, left ventricle. That mitral valve is open. So whatever pressure is in the atrium is going to be in the ventricle. So if my pressure in the atrium is 5, my left ventricular pressure is 120 over 5. Now, in general, the left atrial pressure is usually around 10, and your left ventricular pressure is 120 over 10. LV-EDP, left ventricular and diastolic pressure is 10. All right? So if I have a wedge of 10, I know that I'm good. If I have a wedge of 25, I know I'm in heart failure. Left ventricle is overfilled. If I have a wedge pressure of 1, I know I'm not getting enough blood flow to the left ventricle. The PA only tells me about the lung. The wedge tells me about the filling pressure of the left side. Dr. Swan and Dr. Gans were brilliant when they figured this out in the 70s. Right? Because we had no way to measure what was over there. We didn't have ultrasound. We had echo, but you had to have an echo tech come with the echo machine, and we couldn't even do that in the 70s at the bedside all the time. So this is a mechanism to look at pulmonary pressures and filling pressures on the left side. So let's take it more and look like a tube. When you look at this side, you have the right ventricle on your left side. There's the right ventricle, a pulmonary artery to the lung, pulmonary vein to the left ventricle, and then your arterial system. On the bottom, that's the capillary bed. So remember, the whole idea of having a PA catheter was to have something where we could measure the delivery of oxygen and the consumption of oxygen. So if I wanted to measure what oxygen I'm delivering, I would do an arterial blood gas. But what I would look at is I don't want to look at the PaO2, I want to look at the arterial direct saturations. Not your pulse ox. I want to look at the direct arterial saturations of oxygen. So that should be 100%. So I'm delivering 100%. Every single one of my hemoglobins has oxygen on it, and I deliver it to the cells. The cells utilize it. VO2 demand utilizes that oxygen as much as it needs. Then the venous brings it back to the heart. The heart dumps out its venous blood into the bottom of the right atrium, and then I measure the venous blood in the pulmonary artery. The pulmonary artery is the only artery in the body that has venous blood, and that blood has gone to every cell, your brain cell, your kidney cell, your big toe cell, and dumped off the oxygen that was required. So if I measure that SVO2, true mixed venous oxygenation, it tells me how much the body's demanding. In normal people, if I measure the SVO2, it's 70%. 70, which means my body, in normal use, working, is only using 30% of my available oxygen. I have a reservoir. So that's when you're doing CPR, you really worry about fast and furious CPR, 120 beats per minute, 2 inches down, to pump the blood around because it's well oxygenated. at least for 6 minutes. After 6 minutes, you have to replenish that oxygen. It'll be used. So that's very good. If you do not have a PA catheter, but you have a PICC line, or you have a triple lumen in the right atrium, that's no longer SVO2. It's not true mixed venous. It's SC, central oxygenation. And now we're looking higher. We're going to subtract the venous blood from the heart, and so now it's going to be 75%. So in your PA, it's 70, and your right atrium is 75%, which is very close, very close. So we have a way now to monitor oxygen delivery and oxygen consumption. And remember, that's all about critical care, delivery and consumption. So when you look at an SVO2 or an SCVO2, what you're really just discovering is, what's the cardiac output? What's the H&H? If your H&H is low, it's going to be low. Righty? If you can't oxygenate the patient, your SVO2s will be low, and you're looking at the metabolic demand, how much. So we learned in the 70s, when a patient has a fever, what happens to their SVO2s? Oh, they plummet. When they're in pain, when they have a grand mal seizure, they plummet, because your body becomes hypermetabolic and you use up all that oxygen. Righty? So we want people in pain. You don't want them to have fever. You don't want them to shiver. You want to control their environment as much as possible so we can deliver and decrease demand. Perfect, perfect. Here's again your hemodynamics. Those are just the numbers that we use. But here's another thing to remember. There's the lungs at the top, there's a tunnel, and there's your train. Coming out of the tunnel on the right side is your hemoglobin, and each hemoglobin is completely saturated with oxygen, so you're 100% saturated. Your pump, the purpose of the heart is to drive hemoglobin to the cell, and the pH is normal, the glucose is normal, the hemoglobin is normal. And so as it goes through the tissue demand, it only is going to take 30% out, 25 to 30%. Here it looks like 25%. One hemoglobin is gone, oxygen is gone, 3 are still loaded. So 25 to 30%. It's a perfect system when everything, the heart and lungs, are working right. It's when people are sick that we need to pay attention to this and optimize the patient as much as possible. On the surgery exam, there are many questions about, these are your parameters, this is your hemodynamic profile, what would you do? Are you going to wean something, you're going to give them fluid, you're going to start another drug? That's the diagnostic and monitoring part, and those are very good questions. Now let's just go over the EKG, and there are lots of questions about 12-lead EKGs on the exam. They don't give you a 12-lead to look at, but there are multiple questions. In general, the EKG gives you just, a very brief period of time of the electrical activity of the heart. In a very brief time. How long does it take to do an EKG? 5 seconds. So that's all we're seeing. That's why we do a lot of repeated. So we can look at rhythms, get a better idea about rhythms. If you don't know if the patient's really in V-tach, you get a 12-lead. Look at your V-leads. Look at AVR. Maybe decide whether this is really V-tach or it's just aberrantly conducted. Conduction defects, electrolytes. Now you and I, especially if you work in the ICU, I'm not going to wait for an EKG change to figure out whether I need to do a potassium or not. I'll just send a serum potassium. But you have to know the changes that occur on the 12-lead for that. Drug toxicities, especially like DIG, chamber enlargement hypertrophy, you see different changes in the amplitude of the EKG. And the most important thing for you and I is myocardial injury, ischemia, and infarction. So we're going to do a 12-lead. It tells us about the pump meeting the demands. It really only tells us about the electrical function. It doesn't give you any idea about ejection fraction. Right. Now, 12-lead is just a recording, okay, and this is the normal 12-lead. The P, the Q, the P are interval, the QRS, and remember, not every QRS is a QRS. It could be just an RS. ST, T-wave. T-wave is always asymmetrical. If the QRS is positive, the T-wave should be positive. And not everybody has a U-wave. The U-wave is really designated, we learn about this from Dr. Marriott, that it is a process of when the ventricle repolarizes. And so sometimes when the patient has a QT that's being prolonged, you see that U-wave, and we see that the patient may have reentrant dysrhythmias at that time. So that's normal. There's the ST segment, the T wave, right? Look at that ST segment carefully. If it's above the baseline, below the baseline, so you have ST segment elevation and depression. Where's the J point? Here's where we put our leads, you know, the V leads, right? Sometimes we do 15 lead, 18 lead EKGs where we move those leads to the right side to look for right ventricular dysfunction. And then we have the frontal plane leads, AVR, AVL, V1, 2, 3, right? Those are very important. And I think the most important thing I can tell you, if you're not good with 12 lead, the way to pass this test is to remember 3 things. You have to remember just these 3 things. One is ST depression equals ischemia. Right? ST elevation is what we call current of injury or infarction. Right? And 2, 3, and AVF, those leads, 2, 3, and AVF, are your only inferior leads. All the other leads are anterior. If you can remember those 3 things, any question you have about a 12 lead, you'll get right. You'll get right. For example, they say your patient has ST segment depression in 2, 3, and AVF. ST depression is ischemia. 2, 3, and AVF is inferior. Inferior ischemia. ST elevation, 2, 3, AVF, inferior infarction. Right. So the way that the atria depolarizes is from right to left. It starts in the SA node, goes all the way through Bachmann's bundles, and then down to the AV node, righty. And then here's how your normal ventricle depolarizes. Look at the picture on the left. It goes through the septum from left to right. So the right is going to contract just before the left. The left is thicker. It takes more time for the electrical current to get through it. So you have right ventricular contraction than left. That's normal. That's normal. So when we talk about resynchronization, pacing the ventricles so they resynchronize, it's not like this. It's like this right before left. And the new biventricular pacemakers do that for the patient in heart failure. So in the picture on the left, it shows you why in V1 you have to have an R wave. And it's very important. If you lose the R wave in V1, that means you've lost septal activation. That's showing you septal electricity. In V1, you see there, in V6, you see a Q wave. That's because the wave of depolarization is actually going away. So those are the kinds of things you see on that 12-lead EKG. The first thing you're going to see, and this is very important, the first thing that you're going to see if you're worried about myocardial ischemia is a tented T wave. T wave, remember, is asymmetrical and rounded. The first thing you're going to see is this tented T wave, maybe in 2 and 3, or 1 AVL, V1 and 2. So you see a tented T wave, the first thing you should think of, and just facing leads, is ischemia. If you see a tented T wave in every lead, that's a potassium problem. Right? So the first thing in ischemia is a tented T wave. And then you might see an inverted T wave, again, ischemia, ST elevation in the middle picture there, ST elevation, current of injury, infarction, and then maybe the patient will develop a Q wave, but not all people develop Q waves when they have a myocardial infarction. Only some do. Only some do. So hyperacute T wave, tented T wave inversion, ST elevation, and Q wave formation is what we call the evolution of EKG changes. But you know, not everybody read the book before they come in, and not all patients do that. So in your 12-lead EKG, you do a 12-lead, that's our basic one. If you think the patient's having a right ventricular infarction or something else is going on, you can do a 15 or 18-lead EKG. We've even done 25-lead EKGs. We wrap electrodes all around the whole back and everything, looking for electrical abnormalities. Remember, you're only looking for 5 to 10 seconds here, and they're not ischemic now, but they were, and people have stuttering ischemia, so you're always repeating the 12-lead. Now, here's where we get into electrolytes. If the patient has an electrolyte abnormality, you're going to see it on all 12 leads. Just remember that. That's the best thing I can tell you. Electrolyte abnormalities can affect every lead. Hypokalemia, for us in cardiac surgery or cardiology, this is a big deal because hypokalemia induces ventricular irritability, PVCs, ventricular tachycardia. So we don't want anybody's K to be less than really 4.2 sometimes. Righty? So what you see on the 12 lead, look at the top line there, the 12 lead. That first one that says the K is 2.8, that actually is a little bit low, but you still have an upright T wave. As the potassium goes down, it gets low, the T wave gets flattened. So it's easy to remember. Low potassium, low T wave. It's going to get very flattened, and then you're going to start to see the development of a U wave. Remember, that's telling if the QT interval is prolonging and you have the chance of having reentrant dysrhythmias. So what are you going to do for hypokalemia? You're going to fix it, by giving the patient potassium. But now just remember, in hypokalemia, if they don't have a central line, how much potassium can you put in a little peripheral? Only 10 per hour, and maybe not even that because the patient is painful. You can always give up to 60 MEQs of potassium by mouth. Now, I know you've realized this before, you've seen it in clinical practice, that when you give potassium by mouth, it affects serum potassium much faster than IV. Why? Because you're giving more. And two, potassium is a weak acid and is absorbed readily right through the stomach lining, right into the bloodstream. It doesn't have to go to the intestine, be absorbed, go to the liver, be metabolized. It gets right into your bloodstream. As long as the patient doesn't vomit when you give them that potassium because it tastes so bad, give them PO. It works very well, very well. Now, hyperkalemia. Potassium is too high. What do you see? Look at the bottom line there, and you're going to start to see that example of a tented T wave. T wave should be asymmetrical and rounded. This now becomes very symmetrical and looks like a tent or hyperacute T wave. If you see that in all 12 leads, you know it's a potassium problem. You need to send the potassium, and when it gets high, we have to fix it. So say you call me and say, Cammy, the patient, Mr. Smith, has a potassium of 5.5. And I go, well, I have a sense of humor. I say, oh, that's good. Don't give any more potassium, and we got to get rid of it. So let's give the patient 20 of Lasix IV, 20 milligrams of Lasix IV, and they'll pee it out. But what's the number one reason your patients have hyperkalemia? They've gone into renal failure, and you give them 20 of Lasix, and 2 hours later you take the potassium again, now it's 6.5, and you call me and say, Cammy, that was very successful. Patient peed 12 cc's of urine, and now their potassium is 6.5. I have to do something. And here is sort of the algorithm for hyperkalemia. If it's about 5.5 to 6.5, you can give K-Xlate enemas, usually 2, because that K-Xlate enema is going to pull the K out of the blood, into the rectum, in the poop, and they're going to poop it out. So that's good. They're going to get the K out. Right? But that's only going to last for a few hours because the patient still has renal failure. K is still going to come out of the cell because the patient has renal failure. The second thing we can do is the little bicarb, the D50, an amp of D50, 10 of regular insulin, and some amount of bicarb, and calcium chloride. So the last day I worked, I had a patient who went into acute renal failure. They called me, her potassium was 7.5. So I gave her 1 amp of D50. And the reason I gave her that is I'm going to give her 10 of regular insulin IV push, 10 units. So if I give a D50, blood sugar is going to go up, so I'll protect her from hypoglycemia, but the 10 of regular insulin is going to drive the potassium back into the cell. I'm going to give some amount, and I gave this lady 25 MEQs of bicarb. That also shoves the K back in the cell. So it's the insulin and the bicarb that do the movement. The D50 is just protective. But what does the calcium do? I'm going to give the patient X amount of maybe 500 milligrams of calcium IV, calcium chloride. What does that do? It doesn't do anything for potassium. It doesn't change the sodium-potassium pump. But when you do change the sodium-potassium pump, now the cells are unprotected, and now you don't have good contractility. So calcium protects the cell membrane and allows for good cardiac contractility. So you're protecting the heart with the calcium. Alrighty? The patient's going to need dialysis if they're in renal failure, but you can't get dialysis stat. Even if you're married to the nephrologist, it's not stat within an hour. So we'll do these other short-lived maneuvers, the K-Xlate and the potassium bicarb, that lasts maybe 4 hours. And then it comes back again because the cell is still going to leak out the potassium. So hyperkalemia. Right, protect the heart. Hypocalcemia. Now, hypocalcemia, is going to change the QT interval. And so it can precipitate torsades. But if you see anything on the test about torsades, what's the answer going to be? Magnesium. So if you're a hypocalcemic, you're not going to have good contraction, you're not going to make good blood clot, and you might have torsades. Hypercalcemia can cause asystole. So look at calcium, and then look at magnesium. Holy moly, they look the same. So they're never going to ask you which one is which, but calcium and magnesium can lead to torsades. But this is what I want you to remember about torsades. To call the doctor and say that his patient or her patient has torsades, this is what you have to have. You have to have a prolonged QT interval. Whatever rhythm they were in before, they had to have a prolonged QT interval, and then they have a pause. Whatever rhythm they're in, they have a pause, and then they go right into torsades, alternating QRSs. Right? That's torsades. This is not torsades. Your patient's in normal sinus rhythm, no QTC interval prolongation at all. They have an early beat, they have a PVC, and then they go into what looks like torsades. That's a very irregular ventricular tachycardia. It could be called, oh gosh, what's the name for that? I'll have to think about the name and get back to you, but there's a different name for that. It is called, can we pause it here? Oh my God, what's... All right, now let's look at calcium. Calcium does a variety of different things for your clotting factors and heart function, like we talked about before. But here, hypocalcemia can cause torsades. Now, of course, if you see anything questioned about just torsades on the exam, the answer is magnesium. But magnesium and calcium look the same. They make changes in the QTC. Alrighty, so you're going to have prolonged QTC, and then you're going to have malignant dysrhythmias. So hypocalcemia can cause torsades. Hypercalcemia can cause asystole. So when you go to the next slide and you look at magnesium, they look exactly alike. But a couple of things I want you to remember about torsades. To really make the definition or the diagnosis of torsades, the patient had to have had a prolonged QTC in whatever rhythm they were in before. And then what happens is you see a pause, and then they go into torsades, turning of the points, ventricular tachycardia. That's torsades. If you saw this, the patient had a rhythm, no prolongation of their QTC, they have a PVC, a premature beat, and then go right into turning of the points, that's variant ventricular tachycardia. That is not, and we don't treat that actually with magnesium, we treat it with lidocaine actually. So just keep that in mind, that there are different types of turning of the points, variant or actual torsades. Torsades is treated with magnesium. Hypermagnesemia, like you see with renal failure, can cause asystole. So again, these are just the assessment tools that we use. So your regular assessment, inspection, palpation, auscultation. Auscultation is very important, and you are going to have some very good questions, especially about acute mitral regurgitation in that patient, acute MI. You might have other murmurs and definitely S3s and S4s. So those are things you really need to be able to talk about. And then with a PA catheter, especially in the surgical, there's a lot of questions about PA catheters. Your patient has a cardiac index of 1.7, and they'll give you some parameters, and what are you going to do to fix that, make that cardiac output better. In the cardiac medical, they'll ask you much about medications and the cardiac output and how you're going to make that better and how you're going to assess how can you wean that epi-drip or that Milrinone drip if you're not looking at some parameter. And then the other types of assessment tools that we have, there are not too many questions about echocardiography or ultrasound, although that's the way we really do everything in the critical care area today. If you're interested in echocardiography or ultrasound, in the ICU now we use ultrasound for everything, just go to YouTube and put in normal 4-chamber view of echo or ultrasound. And they will show you a real-time film of the atrials and the ventricles and what they look like when they're normal. So the next time your intensivist or your cardiologist comes by and they bring the ultrasound or the echo and they're looking and you see the 4-chamber view and you go, oh my, look at that right ventricle. It's not very full. What volume would you like? you're going to look really good. You're going to look really good. So you can look at that. Not on the exam, but something to remember. And then the electrolytes. Our physical assessment of the patient includes your physical examination, laboratory findings, and medications. They all go together in your vital signs and in your assessment. So you have to put all the pieces together. The questions are not simple questions. They're complicated questions. Read carefully. The way I take the exam is I read the answers first, then I read the question, then I pick it. Almost every question on the exam has 2 correct answers. So if you just go with the first one you read and you don't read all the rest of them, you might be making a really sad mistake and you won't do well. Read all the answers, read the question, then pick your question. All right, this is it for assessment and extra stuff. Now, next time the next module is going to start with pathophysiology. Thank you, and see you in the next module.